Thank you very much, Dr. Sharini Pillai, for that very comprehensive talk. Now we will go on to the second topic presented today by Dr. Kwok Fan Yin. She is currently a staff specialist in Hospital Kuala Lumpur. She graduated from Wilayah in 2012 with Master Anesthesiology, and she's been spending most of the time in the allergy clinic in HKL, and she's presented multiple times, particularly in the area of allergies and anaphylaxis, perioperative anaphylaxis to be precise. In 2016, she's also a co-author for guidelines in renal transplant in HKL. Without further ado, please welcome Dr. Kwok Fan Yin.
Thank you very much, Dr. Suhaimi, for the kind introduction. So because it's the last lecture, I'm sure everybody is getting very tired and sleepy. I'll try to keep it short and sweet. And it's a very dry topic, as what Dr. Suhaimi mentioned. Oh, sorry. Okay, so renal transplantation is the most effective method of treating end-stage renal failure, as it reduces mortality, cardiovascular complications, and improves quality of life. And according to the studies, graft survival rate at 3 years are about 82% for cadaveric and 90% for living related. So what's our role as anesthetists? So intra-op anesthetic management of recipient is actually very crucial to prevent DGF, which is delayed graft function, failure of the kidney graft to function immediately in the first 7 days with increased need for dialysis. Usually the underlying mechanism is due to acute tubular necrosis. So the rate is low in living donor, but much higher in about 20 to 60% in deceased donor transplant. So how to prevent DGF? So mainly our intra-op management is very important. Mainly we need to emphasize on fluids and hemodynamic management. So in terms of fluid management, type of fluids, volume, and timing of administration will be important. So type of fluids. First, we talk about crystalloids, which is the mainstay, main fluids we use in kidney transplant. Many years ago, normal saline was considered the fluid of choice, based on the belief that potassium-containing solutions like Hartmann's ringer lactate could cause or aggravate hyperkalemia in ESR patient. However, in non-kidney transplants, already a Cochrane meta-analysis already showed there's no difference in mortality, but increase in metabolic disturbances with use of normal saline. So a randomized double-blind comparison of Hartmann's or lactated ringers versus normal saline has shown that there is an increase in hyperkalemia for normal saline versus Hartmann's. And this is confirmed by another paper where the potassium is actually increased by 0.5 millimole per liter in the normal saline group. However, actually 2 patients in the Hartmann's group developed graft thrombosis, but this is the only paper that showed this finding. And another paper on different crystalloid solutions on acid-base balance and early kidney function shows that there's no difference in potassium level, but there's greater acidosis in normal saline and higher arterial lactate levels in Hartmann's. And the best metabolic profile is in plasma-like group, which is the balanced solution. This paper also is a similar paper where they show that there's no difference in post-op graft function, but the plasma-like, again, versus normal saline, maintain acid-base and electrolyte balance, especially during the post-reperfusion period. So another paper comparing the accepted buffered balanced solution versus normal saline undergoing cadaveric renal transplant shows that there's no difference in the creatinine or urine output, but more patients need catecholamines in the saline group. So this is a Cochrane meta-analysis versus normal saline versus lower chloride solutions for kidney transplant. There's actually no difference in the delayed graft function, no difference in the hyper-K, but there is a higher pH and also a higher bicarb in the balanced electrolyte solution. Okay, so this is the result of the Cochrane analysis. There's no difference in the DGF and hyper-K, and normal saline is associated with more hyperchloremic metabolic acidosis than balanced electrolyte solutions. So this is a more recent article from BJ. They compare normal saline versus plasmalite, and there is more hyperkalemia, and patients on normal saline needed treatment for hyper-K, and the creatinine reduction is also better with a plasmalite. So patients receiving normal saline had a greater incidence of hyperkalemia and hyperchloremia and more acidemic. And patients receiving plasmalite had a greater reduction in creatinine on day 2. And this one is also, but this is the only paper that shows that there is a better graft function post-op compared for plasmalite versus normal saline. So there's this consensus statement by the transplant anesthesia of the ASA on fluid management during kidney transplantation. So their conclusion is balanced crystalloid solutions are associated with a better metabolic profile and is a preferred crystalloid compared to normal saline. And after that, there's another paper, again comparing balanced crystalloid solution versus normal saline, and they say actually this paper actually concluded that the balanced crystalloid solution reduced the incidence of DGF compared to saline. This is the most recent paper. However, we know we don't have plasmalite in Malaysia, so we have sterofandin, which is actually it has the similar composition to plasmalite except for a higher chloride content. So we will recommend using sterofandin for all our recipients. So how about colloids? Colloids, mainly we talk about albumin, starches, and modified gelatins. Albumin theoretically has advantages of increased plasma oncotic pressure, enhanced protein transport, anti-inflammatory, and buffering capacity, but it's quite expensive and it has limited availability and it has other issues. Its use in non-renal transplant patients has not been associated with improved outcomes, but what about kidney transplants? So this paper, which is a very old paper on intra-albumin administration, it actually shows that there is improved immediate allograft function and decreased delayed graft function and primary non-function. But after that, another paper in 2014 comparing human albumin versus normal saline shows that there's no benefit than normal saline for immediate graft function in living donor renal transplant. So this paper as well shows that it does not improve early graft function in liver donor renal transplant compared to normal saline. So how about gelatins? There are limited studies on use of gelatins in kidney transplant, and there is a need to consider risk versus benefit. So there's this paper on brain-dead donor fluid therapy with colloids associated with better kidney grafts. Actually, gelatin is the only one that shows that there is benefit on preventing or reducing the incidence of delayed graft function. But please bear in mind, this is not talking about the recipient, it's talking about the brain-dead deceased donor. So how safe is gelatin? So a systematic review and meta-analysis of gelatin-containing plasma expanders versus crystalloids and albumin shows that gelatin, as we know, has higher risk of anaphylaxis, acute kidney injury, and they may need blood transfusion. So it may be harmful by increasing mortality, renal failure, and bleeding. So again, the consensus by this Committee on Transplant Anesthesia only suggests that there's no advantage of albumin over crystalloid, and there's no mention on gelatins. Starches, I think I will just skip this, but basically the consensus is, again, we should not use starches in kidney transplant recipients. So how about volume of fluids and monitoring? So traditionally, we have been trained traditionally to give fluids to the maximum volume to optimize renal perfusion. Older studies actually advocate for maximum volume infusion to the point of no response, and we frequently use CVP to determine adequate fluid resusc. But now we know actually static CVP does not correlate well with fluid responsiveness. And we know it can actually lead to excess fluid, which can damage the endothelial glycocalyx and lead to a fluid shift into the interstitial space, and where the cardiac output cannot be modified. So this is the well-known Starling curve, as we know, where when you reach the flat part, there is actually minimal fluid responsiveness. So this paper in transplantation proceedings, where they discuss on whether do we still need volume overload for graft function, they actually maintain only CVP of 7 to 9 and crystalloids about 15 mL per kilo per hour. And the conclusion is actually we do not need supranormal volume loading to preserve the graft function in kidney transplantation. So the other paper mentioned that the correlates of DGF will be CVP of about 8 or below, recipient age of more than 50, or fluid input of less than about 2.2 liters. And this paper, do intra-op hemodynamic factors affect the graft function? Their conclusion actually the MAP of more than 93 and pre-op fluid therapy of actually less than 2.5 liters lead to greater graft function. And in fact, CVP of more than 11 causes higher rates of acute ejection and chronic graft dysfunction. So this paper actually also shows that the CVP of less than 8 is not associated with DGF. However, the MAP of less than 70 is associated with DGF. So in this paper, they actually they compare patients who were monitored with CVP and those without, and there's no difference in terms of DGF, creatinine clearance, creatinine reduction, and also 3-month renal function. So this intra-op fluid, this paper actually also talk about fluid management and kidney transplant. They actually divide the patient into restrictive versus liberal group. Restrictive means they will receive 3 liters or less than 3 liters of fluids. Liberal will be more than 3 liters. And the conclusion is actually there's no difference. And intra-op restrictive fluid therapy was not associated with DGF or worse outcomes. So this consensus statement by the Transplant Anesthesia Committee of the ASA mentioned that use of CVP as a guide to fluid administration is weakly supported, and there's no robust data indicating harm with CVP used as a guide if the mean CVP was maintained about 5 to 8 without fluid overload. That means we do not aim of CVP of more than 11. So how about timing of fluid administration? There's this study by Osman on the impact of timing of maximal crystalloid hydration. So aggressive infusion of fluid to increase the CVP from 5 to 15 during graft ischemia versus constant infusion actually improved the graft function, and the patient needed fewer vasopressors, and there's less need for diuretics, and post-op tissue edema is also less. And the CVP of 12 at time of declamping and MAP of more than 95 is associated with good early graft function. So again, the consensus statement by the ASA Transplant Anesthesia Committee recommend that the accelerated fluid administration during graft ischemia may lead to improved graft function. So how about other monitors of volume status? So we know that the dynamic variation of arterial waveform derived parameters such as SPV, PPV, and SVV are actually currently the most precise predictors of fluid responsiveness. And this paper compare whether the SVV versus CVP is accurate. And the conclusion is the SVV of 6% can be an alternative to CVP of 8 millimeter. And it may replace CVP in the volume management of patients undergoing kidney transplant. In another paper, actually, the SVV actually is a better predictor of preload in patients undergoing renal transplant. And finally, this paper actually compared pulse pressure PPV, SVV, and also CVP. And their conclusion is SVV and CVP actually exhibited similar performance in predicting fluid responsiveness. This paper actually they use transesophageal Doppler versus CVP, and their conclusion is actually this fluid therapy guided by transesophageal Doppler actually it achieved the same rate as of immediate graft function as a CVP-guided fluid therapy. But there is significantly less amount of fluid needed, and post-op complication due to fluid overload is also reduced. I'll just skip this. Then this is the paper by in a critical care, where they actually summarize all the previous papers that we discussed, and their conclusion is most trials are retrospective, and more robust clinical trials are necessary. So the consensus statement by the ASA Transplant Anesthesia Committee state that there's insufficient data for dynamic monitors of fluid response to make more than a weak recommendation. There's little evidence in the kidney transplant literature to support one method over the other, although these monitors may be better than CVP to assess fluid status in non-kidney transplant studies. So how about our perfusion pressure? So this study actually studied the effect of recipients' hemodynamic status on the outcome of 170 patients. They note that the significant predictors of primary non-function will be a systolic blood pressure of below 110. And this paper on almost 2,000 patients concluded that the MAP of more than 93 millimeter mercury can lead to greater graft survival. And this paper as well support the MAP of more than 95 millimeter mercury. And just now, I think I mentioned this paper before, MAP of less than 70 millimeter mercury was associated with DGF. This paper actually aimed for systolic pressure of more than 150 millimeter mercury and is associated with early stabilization of graft function. Moving on to inotropes and vasopressors. So an old study on low-dose dopamine, actually there is an improvement in the graft function. However, another study further down the line actually shows that there's no difference in patients receiving low-dose dopamine, and is even associated with increased heart rate, ICU length of stay, and 6-month mortality. Phenylephrine also has been shown to be safe, although there is a brief association between phenylephrine administration and slower rate of recovery of the transplanted kidney, but there's no clinically significant outcome. So appear to be safe to give phenylephrine. So finally, there are risk factors. This is a paper on risk factors and outcomes associated with a higher use of inotropes in kidney transplant patients, where they actually use this inotropic score. So if the patient has a high inotropic score, is associated with older patients, patients undergoing second transplant, polycystic kidney disease, more anesthesia time, and actually there is a more higher risk of rejection and also higher mortality. Vasopressin also has been studied before and has been used safely. This is actually quite fresh out of the oven. This just published this year. They studied catecholamine vasopressor exposure on patients receiving living donor kidney transplant, and they have found that poor graft function and DGF occurred more frequently in patients receiving periop vasopressors compared with those who did not, and they also had more post-op arrhythmias. So finally, we are the summary. So basically, we should use balanced crystalloid solutions, which is sterofundin in our setting. We do not give colloids routinely, including albumin, and we do not recommend large volume of fluids, although there's no exact value recommended. Monitor to guide it. There's actually weak evidence for static CVP. Dynamic parameters, there are more evidence in non-kidney transplant operations, but weak in the evidence is weak in kidney transplant. However, we may use PPV or SVV to guide. We should target a higher MAP. The exact value, again, we are not sure. However, studies have shown that MAP of more than 90 and SBP of more than 150 millimeter mercury is associated with better graft function. So inotropes and vasopressors, according to the latest study, we should try to avoid, but if necessary, we should use at low dose to maintain renal perfusion. So our practice in HKL, we do not routinely insert CVL unless indicated. For example, if patient has a cardiovascular disease, if the patient require thymoglobulin, which require central venous access, or if the patient has difficult IV access. And arterial line also may not be necessary, depending on the patient status. We usually just monitor fluid responsiveness by clinical signs and PPV or SVV only if available. And we rarely use a cardiac output monitor like FlowTrack or Vigilio. As a guide, we usually will give about 15 to 20 mils per kilo per hour, and we will run faster before reperfusion. And we use sterofantin. After reperfusion, release of the anastomotic arterial clamp, we will try to maintain the blood pressure as close to the patient's baseline or slightly higher. We may start on intermittent phenylephrine or start on low-dose NORAD to achieve target BP to maintain renal perfusion. So far outcome last year, I think the numbers are quite okay for our center, where we have about living-related 71 cases of living-related, and the rate of DGF is only 1.5%, whereas in cadaveric, the DGF rate is about 20%. So that's all. Thank you very much.